Now, good morning to everybody, and welcome to the first in a series of roundtable evidence sessions in which the inquiry will examine the use of lockdown and other non-pharmaceutical measures as tools governments can consider when facing a public health emergency such as COVID-19. Our aim in these sessions is to explore what governments could or should consider when making decisions about imposing restrictions. Importantly, these are not hearings about actions taken by the Scottish Government. These will be dealt with in our decision-making hearings next year. We will begin by hearing from international experts about the different approaches taken in Sweden and New Zealand to limit or attempt to limit the spread of COVID-19. I'd like to thank today's participants, Professor Sir Ashley Bloomfield, former Director General of Health for New Zealand, and Dr. Anders Tegnell, former State Epidemiologist of Sweden. You've both travelled some distance, in Sir Ashley's case a very great distance, to be with us today, and for that I'm very grateful. Both bring a wealth of relevant knowledge and experience of the pandemic in their relevant countries. I would like to stress at the outset that in having these discussions, the inquiry does not intend to make direct comparisons between the responses of other countries and the Scottish approach to the COVID-19 pandemic during these sessions. We recognise that a range of factors, including cultural, political and economic factors, have influenced each country's chosen decision. Instead, the objective of this session is to help us to better understand what drove decision-making and to hear how each country balanced the trade-offs between the risks posed by the virus and the wider non-health related harms resulting from restrictions. With that, I will now invite Ms. van der Vesterhuizen, KC, to make some opening remarks, in the course of which she will set out the timings of the submissions for any Rule 9 requests that arise over the course of today and tomorrow. I would ask all legal representatives to take note of the timings and, again, adhere to them assiduously. Thank you. Ms. van der Vesterhuizen.
Thank you, my Lord. As your Lordship's already indicated, this hearing session will take the form of a roundtable discussion and has been convened to assist the inquiry in gaining a better understanding of the strategic responses taken by Sweden and New Zealand to the COVID-19 pandemic. The purpose is not to examine or judge those responses, but to understand more clearly decisions that were made, the context in which they were made, and the factors that influenced them. I'm assisted by Mary Ellen Stewart, Junior Counsel to the Inquiry, and I'd like to join your Lordship in welcoming Dr. Tegnell, who will speak about the Swedish experience, and Sir Professor Ashley Bloomfield, who will address the New Zealand approach. Both bring considerable knowledge and expertise and have provided written submissions to a set of questions under 4 themes concerning the use of restrictions and other non-pharmaceutical interventions as a response to the COVID-19 pandemic in their respective countries. Those submissions are available on the inquiry's website and will support the discussion over the next 2 days. The inquiry, my Lord, gave a great deal of thought to selecting comparator countries, and Sweden and New Zealand were identified in part because their responses were distinctive, well documented, and on the face of it at least, contrasting. Both countries have had inquiries into their respective pandemic responses, and reports have been published already. Sweden relied primarily on voluntary measures and avoided nationwide restrictions, whereas New Zealand adopted an elimination approach with strict border controls, quarantine and full population restrictions on movement. Both countries placed communication at the centre of their pandemic strategies, although there were some differences in the method of delivery, frequency and framing. Both countries are also similar to Scotland in terms of having small to medium-sized populations and relatively low population densities outside of urban concentrations. In global terms, they're already of a similar level of economic development, and this also makes them useful comparators while recognizing that their institutional and cultural contexts are very different. The views of the panelists are their own and do not preempt the inquiry's conclusions, and their participation should not be taken either to signify endorsement or rejection of the inquiry of any particular approach. It's recognized that in addition to differences in the approaches taken by the 2 countries, there may also be different professional perspectives, and the aim of this session is to encourage an open exchange so that differences as well as commonalities can be better understood. The discussion will be structured under 4 broad themes, which the inquiry has identified as being central to understanding international responses and which have been addressed by Dr. Tegnell and Sir Ashley in their written responses. And those 4 themes are, firstly, pre-pandemic planning, and the question posed was what pandemic preparedness planning was undertaken by other countries and were plans informed by experience of previous pandemics. The second theme is drivers behind the decision to lock down, and what science-based advice, data sources and models were considered, and how were the outputs of those models used to inform decision-making on lockdowns. The third broad theme was methods of infection prevention and control, and the participants were asked what different mitigation and containment strategies were used to control viral transmission. And fourthly, communication of public health messaging and how public health messages regarding lockdown and other restrictions communicated to the public. In advance of these hearings, Your Lordship issued a document setting out the procedure that core participants should follow in making any Rule 9 applications, and invited them to submit questions or topics to be addressed during this hearing session. There's been a great deal of interest, and the inquiry has received over 350 questions for this hearing session, for which we thank core participants. Given the format of the session and the time available, it will not be possible to cover all of those questions individually. However, they have all been taken into account and they've been considered and used, and those that have been accepted have been used to inform the topics that will guide the discussion under each of the 4 themes. The discussion will proceed in structured sessions with regular breaks at intervals of no more than an hour and a half, probably an hour and 15 minutes, to accommodate the stenographers, and with a break for lunch. My role is simply to facilitate the discussion and to introduce topics for consideration, although there will be some questioning as well. And Your Lordship may also wish to raise issues and seek clarification at any stage. At the outset, and before turning to the first theme, the panelists will be invited to set the scene, and we've set aside a block for this to address aspects of the perspective and health care frameworks within their countries, within which their countries' respective pandemic responses took place. And this will provide very important context for the themes and topics that will follow. My Lord, as I've already mentioned, core participants have contributed questions and topics already that have informed the topics that we'll be covering in the hearing sessions. Those that might wish to make further applications under Rule 6 of the inquiry's Rule 9 procedure are kindly asked to do so as soon as possible to assist the inquiry in the efficient consideration and determination of those applications, with an absolute cut-off of 12:30 tomorrow. My Lord, with that brief introduction, and unless Your Lordship has any questions, I propose now to invite each of the panelists to provide a brief overview of their respective backgrounds before turning to discuss the relevant administrative and healthcare frameworks as background. Thank you, my Lord. Sir Ashley and Dr. Tegnell, thank you so much again for your written submissions. As I mentioned earlier, they'll form the basis of the discussion over the next 2 days. There will be some overlap, inevitably, with what you've already set out in those, but we can take some of those as read, but where appropriate, to allow us time to explore particular aspects in more detail. But I think there will also be merit in having some overlap, because it'll be good to hear your perspectives from the horse's mouth, as it were. So I will be inviting you to rehearse some of what you've already set out. You've both already set out your qualifications and experience, but I'd invite you each now to give a brief overview of those, and also to give an idea of what your particular roles during the pandemic entailed. In the case of Sir Ashley, you were the Director of General Health and Chief Executive of the Ministry of Health in New Zealand, and Dr. Tegnell was State Epidemiologist and Head of a Department of Public Health Reporting to the Public Health Agency in Sweden. So we'd be interested in understanding a bit more about what those particular roles entailed in the context of your broader academic qualifications and experience. So if we could perhaps start with Sir Ashley.
Thank you. Well, thank you very much, and good morning, my Lord, and others in the room. It's a real pleasure to be here. So I trained in medicine and specialised in public health medicine, and I'm still vocationally registered in public health medicine. This is a medical specialty. I've spent most of my career working in the central government at the interface between public health and public policy we call them public servants. I guess over here they'll be civil servants. I did spend some time at the World Health Organization, although my focus there, and indeed for much of my career, has been on non-communicable disease prevention and control, with a particular focus on tobacco control. So saying for the last 15 years or so of my career, I've been more in executive leadership roles in the health system, including as a District Health Board Chief Executive. Until mid-2022, we had 20 district health boards around New Zealand, and I was the Chief Executive of one of those for a period of 3 years before I became Director General of Health in mid-2018. The role of Director General of Health is the senior leadership role in the health system, and in addition to being the Chief Executive of the Ministry of Health, which at the time was around 1,500 people, I had a role as one of the public service leadership team members, so that it comprised chief executives from across the public service, and also that leadership role for the health system. So suffice to say, even if there's not a pandemic, it's quite a busy role. But I was in that role when, around 18 months into it, the pandemic appeared, and found myself therefore leading the health and the public health part of the response to the pandemic through 2020, 2021, and until mid-2022 when I stood down.
Thank you very much. Dr. Tegel, if we can come to you now, please.
Thank you, and thank you very much for inviting me here. I think it's useful for all of us to share experiences, and so that we don't lose all the learnings we have from this huge event, I would say. I mean, public health has probably not seen anything like it for at least 100 years. My training started as an MD. I specialized in clinical infectious diseases, and also did my PhD in infectious diseases, actually in wound infections after thoracic surgery. So I've been all over the place. I also did a Master of Epidemiology at the London School of Hygiene and Tropical Medicine. So that's my training background. I worked as a clinician until the late 1990s, with some periods in WHO in that period. But after that, worked in different agencies in Sweden, but also at EU level. To start with, mainly in control of communicable diseases, but since the last 20 years, a bit more, I would say, in the broad public health. So I worked in different agencies, the National Board of Health and Welfare, which in Sweden mainly deals with hospital services, in-service and stuff like that. But for the last 10, 15 years is what eventually became the Public Health Agency in Sweden. Before that, we had two different agencies, one for NCDs, basically, and living conditions, stuff like that, and one for communicable diseases. They were fused a little bit more than 10 years ago, and I was part of that fusion. And so since then, I've been working in the broad field. I've there been the director of different parts of the agencies, but in the last 10 years, mainly in the area of data collection, data management, data analytics, modeling, those kind of things, for the broad area of public health, not only communicable diseases. And that role was also, during my time, connected to what we call the state epidemiologist. We can discuss that role a bit more later because it's quite complicated, and it has had different ways, both in the organizations and how to use it during time. But that was the reason why I became the spokesperson for the Public Health Agency during the pandemic. The Public Health Agency is one of 250 agencies in Sweden or something like that. So the whole Swedish system very much builds on different agencies. Our government is comparatively small, very much focused on policy, not on technical matters. The technical matters are taken care of by the different agencies, which means that the agencies has a wide mandate. And my former director said we work with everything from Ebola to snuff. And you any kind of question might come to us, and we will deal with it. We will develop the knowledge around it, and we will give advice to the government on how to deal with it, what kind of interventions and so on could be done. But we have on top of that also mandate to actually have legislations in place. When there is a law passed by government, the government will then delegate certain parts of it to, or the parliament will take the law. They will delegate certain parts of the new law to the government to handle, and the government in each turn can delegate certain parts of it to the agencies to actually decide on. So one example in the area of vaccines, we can then, decide on, the government will say which vaccines it will be, we will decide on when they will be given and who will give them. So there is quite a big legal mandate that comes down to the agencies, which also means that agencies have quite a big role in legal matters, and we have a big group of lawyers working for us. And that also transpired into the pandemic, which meant that we were a very central agency in the pandemic. And I sort of became the spokesperson of that because of my role as a state epidemiologist, but also very much because of my role as head of data management, data analytics, which was really a central part of the management of the pandemic in Sweden. So that's briefly what I've been doing for the last 25, 30 years.
Thank you, in a nutshell, thank you. And Surashi, I think you also had some involvement in communications. We're going to come on to discuss communications as the last topic, but what was your involvement, just in a nutshell?
Yes, as the pandemic gained momentum, we started to do daily briefings. Initially, myself and our Director of Public Health, Dr. Caroline McElnay, who's a senior public servant. We did our first briefing to the media at the end of January, 28th of January 2020, principally as a way of dealing with the volume of media inquiries we were receiving as reports from overseas started to come in. And those then segued into daily media stand-ups with either a senior minister or the Prime Minister, and this became especially a feature of the time when New Zealand was in its first lockdown and subsequently. And I think during the course of the pandemic I did around 300 of these daily media stand-ups, usually with the Minister for Health or the Minister for the COVID-19 response, or when the pressure was really on with the Prime Minister. And these became something of, as I think they did in many countries, sort of compulsory viewing. It was where everybody found out what was going to be happening, at least for the next 24 hours, including our colleagues in the health system who would tune into the television or radio to find out just what it was they were expected to do. So that became a key role that I undertook during the pandemic.
Great, thank you. Well, I look forward to coming on to discuss that in more detail with both of you. If we could then move on to the first real topic theme before we get into the first topic, as existing administrative framework is the umbrella, and under that I'd like us to just work through a number of topics. The first is government structures and frameworks. The next is pre-existing healthcare service framework and preparedness. Thirdly, public health leadership roles in your countries, the legislative context, the strategic response and changes to administrative framework. And under those, we've got a number of topics that we'll ask you to cover as well. If I could start by considering the administrative frameworks from the perspective of New Zealand, much of the detail is already set out in your helpful, both of your written submissions, but it would be useful still to have a general overview for the purposes of our discussion. So if I could ask you, Surashi, to start by explaining briefly how New Zealand's crisis management system was structured just before the pandemic, and in doing so, if you could please include an explanation of the roles of the Officials Committee for Domestic and External Security Coordination, the Department of the Prime Minister and Cabinet, the Watch Group, and the National Crisis Management Centre during the pandemic, and also indicate which, if any, of those existed pre-pandemic and which were convened in response to the pandemic.
Thank you. So to brief introductory comments. The New Zealand parliamentary system is very similar to the Westminster style system, except that we're unicameral, and so just a single equivalent of House of Commons. We're obviously a Commonwealth state, and the now King is the head of state. Our public service is politically neutral and very much forms a part of the government when the government is formed. So the government includes the executive and the elected government, as well as the public service. So similar, I think, to the British model. Within the government agencies, there are three what we call central agencies: the Department of Prime Minister and Cabinet, the Treasury, and the Public Service Commission. And Department of Prime Minister and Cabinet, or DPMC, plays a key role in leading the government or government agency work around external and domestic security threats. And the ODESC, as you referred to, Officials Committee for Domestic and External Security Coordination, was an extant body at the start of the pandemic. It is convened in response to crises, essentially, and it has a work program underneath it that is led by a team within the Department of Prime Minister and Cabinet. The group had quite recently been active because we had had an eruption on one of our volcanic islands, Whakaari, or White Island, where a number of people were killed and others very seriously burnt, and so the ODESC was stood up immediately in response to that. So it was an extant and an essentially well rehearsed group. The ODESC, as you've said, is or referred to, is convened by the Chief Executive of the Department of Prime Minister and Cabinet. It operates as a collective. The membership comprises chief executives of most of the key government departments or agencies, and when an issue is forming, a watch group is set up. So these are set up in response to specific issues, and the membership of a watch group would include the pertinent agencies with respect to that particular issue that might be emerging. And whatever the nature of the crisis, there is a lead agency identified, and clearly for the pandemic, because it was a public health crisis, the Ministry of Health was the lead agency. So both ODESC and its watch groups were a mechanism that were well established and well rehearsed at the time the pandemic emerged. So saying just one other point I'd like to make here is that the government agencies, ODESC, and this applies right through the pandemic. The role of government agencies is to provide advice to the government, and the decision-making body is the Cabinet, very similar to, I think, to the British system, known as the executive. So whilst it might have been implied at various times that the Ministry of Health or other officials were making decisions, in fact all decisions are taken by the government and invariably by the Cabinet. So that was the mechanism that was in place at the time the pandemic started.
Thank you. And just in relation to those that were extant at the start of the pandemic, broadly, what was their membership? And in particular, were they all of government or more focused?
The ODESC tends to be an all-of-government group, so quite a wide membership. The watch group would also have members from the equivalent departments. Because, and we found this, of course, during the pandemic, but most situations where a crisis occurs, it requires an all-of-government response in some way or other. And this was very much the case, of course, for the pandemic.
Thank you. Dr. Tegnell, you describe Sweden as having a highly decentralised public administration, something we're possibly familiar with in parts, but less familiar with in New Zealand. And you describe there are three main levels of government, namely national, regional, and local. Could you briefly, please, give an overview of those and also describe how responsibilities were divided between national, regional, and local levels before the pandemic, as well as the role of the independent agencies, in particular the Public Health Agency, the National Board of Health and Welfare, and the Swedish Civil Contingencies Agency, or MSB, and their relationship with government?
Yeah, That's a rather big question.
It's huge. It's all in your name.
Let's start with the three levels. The national level, well, let's start at the bottom. I mean, the local level is taking care of social services, schools, elderly homes, those kind of things in general. And there is more than 250 of those, and they vary size from maybe 6,000-7,000 people up to 500,000. So it's quite a... and then that level, as all three levels, have their own political constituency. They have a parliament, they have a kind of government, they levy their own taxes. So they're very independent in doing what in the legal system is possible for them to do. The next level is the regional level, who basically concentrate on running healthcare services, but also responsible for public health. They're also responsible for culture and roads and a few other things, but most of it goes to... and once again, they have their own parliament, own voting system, levy their own taxes and all of that. And then the national government, of course, can put laws and stuff like that into place, but has a very limited operational both capacity and role in running public health in different ways. In a crisis, the Swedish preparedness system and a crisis management system builds on one principle that's very strong, and that is whoever has responsibility for something in peacetime will also have it in a crisis, which means that we do not really change the structures at all during a crisis, but it keeps on running in the normal structures that we have in place normally. So there is no way of sort of taking over the decision-making or mandate for anybody in this, unless government and parliament gives a go-ahead. So during the pandemic, that also happened. I mean, the communities kept on running the schools and the elderly homes and so on. The regions kept on running the health services. And the national level mainly focused on seeing what legal things needed to be put in place, and also in coordination in different ways, and of course handling the international, all of these kind of things. And at the governmental, the national level, Swedish agencies has, as I was a little bit saying before, has a stronger role than agencies in most other countries. They are, by legal mandate, independent. The director is put in place by government, but done in an open process with the most qualified person getting the role, at least officially. So, and then all the people in the agencies are employed by the agency. And the agency gets its money yearly with certain instructions from the government, but quite open. So what the agency does within its mandate is very much up to the director and the agency itself. So there's quite a lot of independence in it, even if there is, of course, continually a very close communication with the political level. In the end, these bodies are, appointed by a legal act. So they have a very strong legal mandate in many ways. And that's also what happened during the pandemic. The mandates did not change, not at the national level either. The government sort of kept its role as a lawmaker and to take care of what things needed to be done at that level, and the agencies took care of their respective role that had in peacetime kept those. What was special this time is, and we don't really have a system where one of the agencies can become a lead agency. All the agencies are basically at the same level. But in practice, since this was very much of a public health, it has consequences for everybody, but the core of it was public health. The public health agency became sort of the lead of it. And the government made that clear by issuing a directive that we should have daily press conferences together with the National Board of Health and Welfare, who took care of the hospital services, and with MSB, the continuous agency, who takes care of the civil response in the society, together with the regions and together with the communities. So that, and I think that sort of also implied how the government sort of saw who was going to sort of help in leading this, even if the operational aspects, all of them were basically taken care of by the communities or the regions. So we kept on having these daily press briefings, those three agencies. There were also occasional press briefings from the government level, not that often, and mainly when the government sort of needed to go in and do some kind of legal change in the structure or something like that, or so other reasons for them to be. But otherwise, this was very much technical kind of things. We did 198 of them, so during the 2-3 years. So that's, yeah, it is a fairly complicated structure, which builds very much on grassroots contact, and with all the strength and the weaknesses you have in that kind of system. So, and the Public Health Agency has a very limited possibility to actually enforce what the regions should do or what the community should do. So it very much builds on networks and giving them good advice on what's reasonable to do. And we had twice weekly meetings with all our contacts out in the regions. Each region, by law, has a communicable disease officer.
And we'll come on to ask you in more detail about that. But if I could just ask you, you mentioned, I think, that with the funding come instructions. What sort of instructions?
They would mainly be that the government saw a problem, and they wanted to have advice on, or technical, scientific background to what can we do about this. I mean, a recent example is all the screens we are looking at. They were asking us, okay, what do we know about the problems with screens? What could we possibly do, especially in children, when it comes to screen time and so on? And then we would put together a group, internally and externally, and deliver advice to the government. Okay, this is what we think is reasonable to do in that area. So it would be those kind of instructions.
Thank you. And is the funding connected or linked to a particular instruction, or is there funding there?
The big part of the funding is constant, and it's not connected to any specific instructions. But sometimes when the government sees that this is a very big thing they need to do and is sort of outside of the normal scope, there will also be added funded for specific inquiries like that.
Thank you. Could I just ask you, and you've probably touched on it already, but just to explain the principle of decentralization?
Yeah, I mean, it means that, of course, there are laws in Sweden regulating how health services should be delivered to the population, for example. But the laws are quite open, very much oriented towards this is what you're supposed to achieve, not what you're supposed to do. I mean, there is no law saying that you need to have so and so many hospitals and so many beds or anything like that. But it basically says that you're supposed to deliver healthcare to your population in an equitable manner, and it should be similar to what's delivered in the rest of the country. So that's how sort of the regions, and in a similar manner, the communities are regulated on what they should do in a very much oriented towards what are they supposed to achieve, not how to do it.
And in terms of the NBHW and the MSB, what are their roles?
The MSB's role has by many been considered vague, but because their role is mainly to assist the different parties, because they don't really have an operational role of itself. So their role is mainly to assist the different partners in the Swedish civil contingency system in improving their preparedness and improving their capacity to manage a crisis. And then they have a vaguer role in collecting information during a crisis and supplying that to the government. So what they did during the pandemic is that they asked the regions and the counties to deliver weekly updates on what is happening, and they put those together into a sort of report on what's happening in the civil contingency side during the pandemic, and made that public and also available to the government.
Thank you. I'd mentioned that we were going to come on to discuss health services framework and preparedness, but since you've mentioned it, perhaps we could talk about public health leadership roles for a moment. And I think, Dr. Tegnell, could you please explain the role and extent of the authority of the communicable disease officer in each region, including how their independence is exercised in practice, and whether or not they're part of the public health agency?
The regions have an obligation by law to put in place a communicable disease officer who is actually an agency, a legal agency in itself. And the size of it differs, of course, because the regional size differs from like 60,000 people to some 2.5 million people. So sometimes it's 1 or 2 persons, and sometimes it's a whole group. But there is one person who has this sort of legal mandate to be the communicable disease officer. The mandate mainly implies that when you do test and trace activity, and the persons that you trace are not following the rules of the physician, because the test and trace obligation lies with the health system, not with the communicable disease officer. But she can step in when the persons do not abide by the rules and so on given by the physician in charge. And they can even contact the police and so on to enforce certain restrictions and stuff like that. So that's the legal role. Then, of course, he has a kind of advisory, coordinating role in improving the communicable disease control within his region. And
what is the relationship with the region?
From the national level, you mean?
No, with the region, the communicable diseases officer in each region. What is the relationship with the
person is put in place by the region, but independent from the region. We have had a lengthy discussion where they should sort of sit in the system. But when you come down to sort of the legal point of it, it's definitely this person is independent and takes his own decisions outside of the region, and has a kind of supervisory role, I would say, both in communicable disease control within the hospitals, but also outside of the hospitals.
The Corona Commission, I think, had commented that the system of communicable disease prevention and control was and is decentralized and fragmented in a way that makes it unclear who has overall responsibility when the country is hit by a serious infectious disease. Do you have any comments on that observation?
It is true to a certain extent, I would say, because the Communicable Disease Act is very much focusing on the individual and very much focusing on sort of test and trace around the individual and those kind of aspects. So it has a very much of a focus on that, and that's historically because the Act was very much developed during early HIV days. Mm-hmm. So this was very much in the minds of people in those days, and that's really what the Act focused on. It is not very well adapted to a mass casualty, mass situation, and that is taken care of right now because we have an inquiry ongoing looking into how can we further develop the Communicable Disease Act to be more focused also on these mass events. This time we had to rely on a number of other laws to be able to do what we needed to do during the pandemic.
Well, we'll come on to ask you a bit more about that in a moment, but perhaps if I can just, on the subject of public health leadership roles, ask Ashley, you mentioned in your written submission that New Zealand does not have a chief medical officer or CMO equivalent to Scotland. Please could you explain how the Director of Public Health, which I think you say is the closest to the role of the Scottish CMO, fitted into the system, and what their duties were and the extent of their authority?
Sure. So the Director of Public Health is a statutory role. It's appointed by the Director General and is required to be a public health doctor. And that person provides public health advice to the Director General of Health and to the government. One of the duties of the Director of Public Health is to designate medical officers of health who are the equivalent of the Director of Public Health, but out in the regions. And the medical officers of health have statutory powers, for example, to require individuals to isolate or undertake quarantine if they have an infectious disease. The medical officers of health are not employed by the Ministry of Health, rather were employed by district health boards and worked in one of 12 public health units that covered the country. But they have a very strong link to the Director of Public Health, and who organises training of them, as I said, is also the person, along with the Director General of Health, who designates them to have the powers that they have and can withdraw those powers as well. During the pandemic, the group of medical officers of health was in daily contact with either the Director of Public Health or one of her deputies, so convened on daily video Zoom meetings or teleconferences. So in a sense, a national team of people with those statutory powers to help lead the public health response in each of the regions.
Thank you. If we could maybe then turn to discuss the legislative context briefly, and this is again set out helpfully in your written responses. So Ashley, if I could ask you first, though, to just give us an outline of the extent to which New Zealand's existing Health Act, 1956, Epidemic Preparedness Act, 2006, and don't worry, I won't be asking you about specific provisions, and the Civil Defence Emergency Management Act provided sufficient legal tools at the start of the pandemic to enable initiation of early infection prevention control measures, or whether new legislation was needed.
Thank you. Yes, so I think the date of our Health Act says something, 1956, and there have been attempts to completely rewrite and update that legislation that have not been taken through to completion. So saying that Health Act has been updated and amended a number of times. And it is under that Act that, for example, the Director General of Health's powers are contained, the powers of the Director of Public Health and medical officers of health. It is a very full Act. Following the SARS outbreak in the early 2000s, in response to that, the Epidemic Preparedness Act 2006 was enacted. And that distinctly enables the Prime Minister to create an epidemic notice when there's an outbreak of a quarantinable disease that is likely to be significantly disruptive. And of course that was the situation we had with the start of the COVID-19 pandemic. And that epidemic notice then triggers a number of other powers in other legislation to support a response. Finally, to complete the triumvirate, the Civil Defence Emergency Management Act establishes the framework for preparation for response and recovery from any sort of emergency, and that Act was also invoked in the pandemic because it allows national states of emergency to be declared, and that then gives powers to local civil defence controllers to undertake certain activities. And it allows resources then to be deployed from a national level to help local responses as well. It also grants extraordinary powers to the national controller, who's usually the head of the equivalent government agency for emergency management, and so that those were the three pieces of legislation in place at the start of the pandemic. But it very quickly became apparent, especially once we were in the first lockdown, that a bespoke piece of legislation was required, and a new COVID-19 Public Health Response Act was assented by our Governor-General on the 13th of May 2020. And one of the things in particular that Act needed to do was, in fact, to provide a legal basis for lockdowns. The legal basis initially had been the power that the Director General of Health has got as a national medical officer of health to require people to quarantine or isolate. And in fact, it was determined subsequently by the court that that didn't really extend to the entire population being required to quarantine and isolate. And I'm sure we'll come back to that in due course when we get to talk about the equivalent of lockdowns as New Zealand implemented.
Just in general terms, how, to what extent did the need to pass new laws or a new law affect the speed of New Zealand's response?
Well, I guess as the subsequent court case showed, we didn't let perhaps the lack of a bespoke law stop us from taking quite significant actions, including what transpired was a request for people to go home and stay home until otherwise told. And again, I think we'll pick that up because the I think a key thing in this, I'm sure will come out in our discussions, is the extent to which the law, or indeed any law, can be enforced through legal enforcement, and the degree to which any law requires public trust in the purpose of a reasonable law or a reasonable instruction, and the trust not only in the government that it's a reasonable request or a reasonable law, but also trust that most, if not all, other people will comply with the request or the law. So the legal framework provided a very adequate basis for the initial response in New Zealand. However, it was also felt that bespoke legislation was required, and that was enacted quite quickly.
Thank you. Dr. Tegnell, in Sweden, the Communicable Diseases Act 2004, which you've already referred to, provided a framework, but was also focused on the individual rather than society. It sounds not too dissimilar to New Zealand's legislation. Could you please explain the extent to which this and other legislation allowed for a response to the COVID-19 pandemic in Sweden, and in particular, whether there was sufficient to enable infection prevention control measures to be initiated, or, like in New Zealand, a state of emergency to be declared?
Well, let's start with the last one. It's not possible in Sweden to declare a state of emergency. That kind of change of mandate is not within the legal system. And as I said, the whole system in Sweden builds on that you have the responsibility that you have in peacetime, and your responsibility is really to keep on running whatever services you are obliged to in peacetime, also during a crisis. And each actor really has a responsibility to build up a system to be able to do that in different ways. So that's the basis for that. Yeah, as I said, the Communicable Disease Act is very much an act that deals with handling the individual and smaller outbreaks, not for the big ones. And that was discussed a lot, and eventually there was a pandemic law passed in Sweden to give. That was not used basically at all, I would say.
Are you referring to, there was temporary emergency laws in spring of 2020, yeah, and then the Pandemic Act in January 2021. Yeah. And then I think there were amendments to the Temporary Infection Control Measures at Restaurants and Bars, yeah, Act, which is quite a mouthful. Yeah.
So what happened instead was that we made provisions in existing acts in other areas. For example, when it comes to restaurants, which are very heavily regulated in Sweden when it comes through our alcohol legislation. So that was used as a basis for regulating the restaurants. Big gatherings were instead regulated through other acts. I think in the aftermath we all agreed that this was not a very efficient way of doing it, because it became too blunt. We couldn't make the adjustment to different kind of services and different kind of big meetings and so on that we thought were necessary. For example, religious services and so on ended up under the same act, which didn't really make much sense. So, and that's why we had this ongoing inquiry to look into what kind of other legal measures do we need to have in place to be able to be more focused when it comes to regulating different parts of the society next time.
And you touched on it, so Ashley, but we'll come back to more detail later. But just while we're on this, Dr. Tegnell, how were the restrictions that were legislated? Although I appreciate you say they weren't used that much, but how were they restrictions that were legislated or recommended enforced?
They were enforced to, I mean, if we take the restaurants as an example, they were enforced during the normal system, which means that the county boards, apart from the regions and the communities, we also have counties, which are a kind of coordinating role for the communities. So the county board then have an inspection role when it comes to that the restaurants actually follow the rules that are in place. And that role, together with the communities, they also had during this. So when there was a change in legislation for the restaurants, they had to go and inspect. And those powers, they can close down a restaurant if they don't feel that they follow the rules and regulations in place. So that was the system that was also used in this instance for regulating the restaurants. When it comes to big gatherings, that goes back to a law that the police handles about allowing big gatherings. And every time you have a big gathering in Sweden, you need the police to ask the police for permission to do that. And so that was, since the police did not give permission to big gatherings anymore, because that's what the new regulations said, they also were the ones to enforce that it did not happen.
Thank you. Before we move on to just discuss the strategic response overview of that and changes to the administrative framework, could I ask you both about your existing healthcare services framework and preparedness, including in relation to how well prepared your systems were for the pandemic in terms of things such as hospital and ICU capacity, communication and coordination between service providers, and whether there were any particular vulnerabilities, for example, in relation to workforce or ageing infrastructure that became apparent as the crisis unfolded. And if I can perhaps ask you, Sir Ashley, to start on that one.
Thank you. It's another big question. So
big.
They are all big. So forgive me if I don't cover all those things, but please prompt me. So New Zealand's health system is interesting and probably similar to the United Kingdom and here in Scotland, where the Crown has both a funding role and an ownership interest, in that all the hospitals, public hospitals, are owned by the Crown, and the staff who work at those hospitals are employed effectively by the government. And that accounts for about 50% of the funding that goes into the health and care system. The other funding, which it pays for subsidies for general practice, aged residential care, pharmacy, mental health services, Māori and Pacific providers, and so on in the community. That funding was used to commission those services by the district health boards. So the district health boards, there were 20, had hospital services they would run, and also commission services in the community, and they also owned and ran the public health services in the community. It's fair to say that at the start of the pandemic, and this is still an issue for New Zealand, in the period after the global financial crisis, as part of the government's response to that, there was a lower investment in lower capital investment that was needed to both provide for the upkeep and the replacement of hospital services. And this was compounded by the fact that New Zealand, one of the other names for New Zealand is the Shaky Isles, and we had a series of quite big earthquakes that then saw a requirement for quite stringent seismic strengthening on buildings, including many of our hospital buildings that were decades old. So there was insufficient capital put into the system for a number of years, which left us in a position where probably we didn't have sufficient hospital beds, and we certainly have one of the lowest number of ICU beds per capita in the OECD. That's not to say that our hospital care and our ICU care is not of a very, very high standard, because it is, but this became a particular concern at the start of the pandemic, when we could see what was happening in northern Italy and in the UK and in New York in particular, and the overwhelming of both hospital care and ICUs. So there were quite significant efforts put into essentially repurposing beds and ventilators that would otherwise be used in theatres to be able to be used to supplement our ICU capacity. So at the start, we had challenges around hospital bed numbers and ICU bed numbers. I would dare say, though, it's one thing to have a bed, but the most important thing about a bed is to have staff to attend to people who require those beds, and that was an issue as well. So I guess you could say we had the triumvirate of ageing infrastructure, insufficient hospital and ICU bed numbers, and probably insufficient workforce to provide care. And I dare say that as we watched what was happening in other countries, this was one of the key drivers of decision-making around the New Zealand response. And what did become apparent from what we could see was actually it didn't matter how many ICU or hospital beds you had. Once your system got overwhelmed, it was overwhelmed. And that was a very important driver of the decision then for the government to look at other options. Initially, a suppression approach to manage within the capacity of the hospital beds and the health system, but then that changed into an elimination approach subsequently. Have I forgotten anything? Please remind me.
Not off that list, but I'm going to ask you just before I turn to Dr. Tegnell, what about the general health of the nation? What was the status of that, and how vulnerable, or what sort of a vulnerability was that?
So New Zealanders enjoy, for the most part, very high level of health. Our life expectancy is very good by international standards, and our health system delivers high quality care. The big challenge in New Zealand, and I know this is an issue for many other countries, there is the differences or inequalities within the population, and some of those inequalities are unfair, so we call them inequities. And again, a key driver for our decision making was our knowledge that there were groups in the population, including our Indigenous Māori, our quite sizable Pacific population, people with disabilities, people with mental health, long-standing mental health and addictions conditions, who would be more vulnerable. And that was a key driver of our decision-making too, was considering the impact that the pandemic would have on those known groups that had poorer health, and also, of course, it was very apparent early on that older people were a particularly vulnerable group. And they are, as they are each year, to the annual influenza outbreaks that happen.
Thank you. Dr. Tegnell, I'll repeat the question because it is quite long. Could you please tell us how well prepared Sweden's systems were for pandemic healthcare systems in terms of things such as hospital and ICU capacity, communication and coordination between service providers, and whether there were any particular vulnerabilities, such as in relation to workforce or ageing infrastructure, that became apparent as the pandemic unfolded?
I think there's a lot of similarities to what my colleague from New Zealand just have said. As I said before, I mean, the health system is federal, I would say, in the 21 different regions, who, of course, has a general mandate to do certain things, but do it in a slightly different manner. And to a certain extent, that, of course, makes sense. You run a healthcare service different in a remote area up in the north of Sweden, with maybe a population of 1 person per square kilometre, compared to Stockholm. You have to run one for 2-3 million people. So there is strength in it, of course, but also problems when you have bigger common problems. So that's, I'm going to come back to that. The health services is also one of the problems, I would say, is that some 40-50 years ago there was a division in obligations between the communities and the regions, and the long-term care was moved from the hospital sector to the communities and became a kind of social service instead of a health service. And can I just pause there? When you say long-term care, what are you referring to? Yeah, any kind of elderly care, any kind of even medical care for providing a place for people with long-term problems, a place to live and so on. The system in Sweden has also been very much pushing for home care. So the number of beds have been diminishing rather drastically over the years. So we have been, compared to most other countries, we have very, very few hospital beds, partly compensated by that the communities run what in other countries probably would be said to be a long-term care facility. But the communication between the two are very varying, and actually the communities are not even by law allowed to employ doctors to run these services. They are run by nurses to a certain extent, but mainly by people in social care. So that's definitely a weakness that was well documented and well known, and we all were quite worried about what's going to happen to this kind of elderly homes in Sweden during a crisis like this one, because we knew from flu and so on that they were really very open to having big problems doing that. And they are really catering, since home care is pushed so much, these are the people who are really very old, very frail, and very sick. And I think the mean survival time after moving into a home like that is somewhere between 6 and 8 months. So these are, and it's only like 10,000 people living there out of 2 million people above 65 and so on. So it's a very, and it also proved to be a big problem, and we can come back to that. So that's one of the problems in the system. The other problem is, as I said, that the number of beds have gone down. We have a problem with staffing, as you said. We don't have problem with beds, actually. We have problem, especially nurses who don't feel that the regions are very good employers, so they tend to go into private to move to other countries like Norway and so on. So, and this is a big problem. We have also, relative to most other countries in Europe, fewer intensive care beds. But since the system is very much in one hand in each region, there was a possibility to actually compensate for that, and establishing, actually we doubled the amount of intensive care beds very, very quickly during the first spring. And it was done by moving staff from other services. So, not always very successful. My daughter is an intensive care physician. She tells me about that you cannot get orthopedic surgeons to work as nurse assistants in intensive care. It's just not the way to go. So a lot of learnings from that. But intensive care actually managed to handle this. And we had always open place in intensive care in Sweden. But that was also very much because quite a lot of elective surgery and so on was pushed off, because the other problem in Swedish healthcare is the long waiting times we have for elective care, like hip replacements and so on, which is continually discussed and not handled very well. Thirdly, when it comes to supplies, the Swedish healthcare system works on what I would call an IKEA system, which means that you don't have anything in stock anywhere. Everything is just on the road between different places. And this, of course, works very well in peacetime, but proved to be a huge problem during this time. So that really also a thing that we knew about and we had reviewed repeatedly, but not really taken care of, mainly because there was a big discussion between the national level and the regional level, who should take the cost for setting up this. So this was really a fight in the beginning to be able to get face masks and all these kind of things in place, because there was not really the system in place so that you could have those. So there was a lot of challenges, but in the end, the Swedish health system does in peacetime, just like the New Zealand, delivers extremely good care. I mean, the outcome of cancer treatments and so on is really top-notch. And actually managed to continue to do that through the pandemic. And I think they can be really proud about that. They managed both to take care of the COVID patients, but also managed to give reasonable care to the rest of the patients.
Thank you. And then also to ask you about the health of your nation and to what extent that was a vulnerability or not. The general health.
I think we are quite comparable to New Zealand. We have a very high level of the average age in Sweden is very high, especially among men. We had a rather surprising development that the increase of average age of men has moved on while women has leveled off. Don't quite understand why. There's quite a lot of discussion about that. And I would say in general the population is very healthy. The number of unhealthy years towards the end of your life is very low in Sweden, which I think is even more important than average year. And it has in spite of that, average age has increased. The number of unhealthy years has kept very stable over the years, which shows that it's a very healthy population. On the average and on large, but as in New Zealand, we have a small minority of people who fall behind for a number of different reasons, socioeconomic, different handicaps and so on, and that part of the population is falling behind even more. So our health equity is increasing, and it increased even more during the pandemic because those groups were hit much, much worse. We could see that among our migrants being born or having parents being born in Somalia and living in Sweden, your risk of getting into an ICU was 7 times higher than a comparable person born in Sweden or with Swedish parents. So those groups really suffered.
Yeah. Well, thank you very much. I don't know if you had anything else to add to that before we move on to our last topic under this heading.
Perhaps I could just add one point, and this is to contrast with Sweden in that our home and community support services, which are largely for older people who are being supported to live in their own homes, and our aged residential care services are part of the healthcare system. Both are funded through through Vote Health, and we have, just to sort of set the scene, in our aged residential care sector, we have a much higher number of people in that sector, in those facilities. There are 660 such facilities in the country, around 40,000 people, and there are 3 levels of care: rest home, hospital level, and dementia level care. And so this was a setting that we knew would be very high risk had the virus the virus got away in terms of an outbreak, and it was one we put a lot of effort into ensuring that people were looked after, and I guess we'll come to that. But just again to emphasise that they're very much a part of our healthcare system, so we're very much. Whilst it's not a command and control system, in fact, the links were well established. They have peak bodies that had very close relationships with both the district health boards and the Ministry of Health. So there were very live, extant mechanisms for communication and for developing up guidance, especially around infection prevention and control and so on. Thank you.
Thanks very much. Well, our final topic under the administrative framework is strategic response, or early strategic response, and changes to the administrative framework. And we will come back later to talk about the strategic response in more detail. But before we move on to pandemic planning, it would just be helpful to get an overview of the early strategic response and changes to the administrative frameworks that were required. I think we've probably touched on some of this already, but Sashi, could you please outline how New Zealand's strategic approach evolved from the early cabinet-led response through to the adoption of elimination, which you've mentioned already, and I think it's referred to as going hard and early, to suppression and mitigation, including an explanation of what those terms mean, please.
Very good. Yes. So I think for New Zealand, like most countries, the initial response was very much predicated on the planning we had done around our influenza pandemic planning. What became apparent quite quickly when we saw what was happening internationally was that we didn't have an influenza pandemic. In fact, we had a COVID pandemic, and that our planning was not necessarily going to see us achieve what we felt we needed to achieve. I think of the key objectives as fourfold. One was around preventing infections and deaths from COVID-19, and in particular, and I've mentioned, our most vulnerable groups. And of note here, and it's important to emphasise this because I think each country's response to the pandemic is very much situated within the historical and social context of each of that country. And for us, back in the 1918 Spanish flu pandemic, this had been particularly hard on our indigenous Māori populations that had a death rate 7 times higher than the rest of the population. And in fact, very early on in COVID-19, we saw our more remote Māori communities, and they're very anchored around their place, take their own measures in terms of checkpoints on roads to stop people coming in to their rohe, in their area, unless they knew who they were and could be confident they weren't bringing an infection in. And so there was, because Māori is was not a written language when Europeans first arrived in New Zealand, there's a strong tradition of orally passing down information. There was a very strong memory of that, what had happened a century ago. So that was a key factor that shaped our response. I've mentioned the fact we wanted to prevent our health system becoming overwhelmed, and that we could already see was happening in countries around the world. We did want to protect the country's economy and economic and social well-being to the greatest possible extent. And finally, we felt we had a responsibility to other countries in the Pacific. And New Zealand has a very large Pacific Island population, and we had both distant and recent history that is important here. Back in the Spanish flu pandemic, a boat left Auckland, travelled to Samoa, and took with it the flu virus and the influenza virus, and a third of the population died as a result of that. And just the year before, we'd had a measles outbreak in Auckland, with no deaths, over 1,000 cases and no deaths. An infected person travelled to Samoa, and in that country, for a range of reasons, there were over 70 deaths, a much smaller population, and many of those in infants and young children. I had just commissioned and received the outcome of a review of our response to that. So this was very much in our mind. So just briefly then, it wasn't intended, but when we went into our first lockdown, in quotes, we had intended to take a suppression approach, but it quickly became apparent we could eliminate the virus, and we moved into an elimination approach that became the basis for our decision-making and actions subsequently for around 18 months. We can go into the detail of what that involved perhaps a little later. The purpose of the elimination approach in New Zealand was to protect the population and achieve those other objectives until we had a vaccine, an effective vaccine, and sufficient vaccination coverage to then be able to move back to more normal measures, knowing that the vaccine would protect people, and that happened towards the end of 2021. And that's what we then called perhaps more of a suppression approach from that point. So the majority of the time during the pandemic, our response was characterised by an elimination approach, and I can either go into the detail now or perhaps subsequently about just what that entailed.
Okay, I'm just going to mention to His Lordship, I think we have a break scheduled for 11, but if we were able to press on, we could probably finish this theme.
I have it down for 11:15, so you probably don't need to try too hard here.
We'll continue, thank you. Yes, we can perhaps come back to discuss that when we, under the lockdown or restriction under theme 2. But perhaps in the meantime, I can ask Dr. Tegnell, Sweden moved quickly from containment to mitigation with the PHA leading the response rather than the government. Could you please explain why the PHA led the response? You've obviously explained a bit about the link, but what it meant in practice in terms of the nature of decisions it was taking itself compared to the types of decisions the government was taking.
Let's just start with the context, because I mean there are many similarities between New Zealand and Sweden, but there is also huge differences. I mean, Sweden is part of the Nordic region. We have had open borders for the last almost 100 years, no passports, nothing. So a lot of people move across the borders all the time. Just in the south of Sweden, more than 60,000 people commute every day between Sweden and Denmark and live in one. And so. And the other thing that happened was that this pandemic started in Europe during our winter holidays. And 10% of the Swedish population go abroad. So 1 million people come back within a week or two, mainly into our big cities. So we had the policy of on containment for the first few months and managed that reasonably well. We caught a number of cases during that, and help of testing and tracing, we did not see any spread. But when these 1 million people came back with the disease from all over the place, basically, our system was quickly overwhelmed, and there was no way that we could handle the containment anymore. We had so much spread, especially in Stockholm, in the surrounding area, but also in other parts of the country. So that was why we shifted. And that was very much a decision taken after hearing from our regions that there is no way we can both test and trace 1 million people and take care of a rising number of cases in our hospitals. There are limits to how much we can do at the same time. You can always discuss who took the lead or not. I mean, as I said, I consider that we had the same division of labor like we do normally, but that means that when it comes to technical matter, and this remained a technical matter to a great extent in Sweden, the Public Health Agency, together with the National Board of Health and Welfare and MSB, were the ones that sort of were mostly seen, were the ones who sort of told what's happening and also gave ideas what we can do about it. And I think, and that's discussed quite a lot right now in Sweden, I think that we were a broad public health agency and that we work together with other agencies normally also very much did that our response was not solely focused on stopping the spread, but very much focused on protecting vulnerable groups, protecting our health services, and not least protecting other services in society so our society could keep on functioning. Because we understood once we were overwhelmed that this pandemic we're not going to be able to stop it. There's absolutely no way we can do that. And it's going to last. And as I've often said in interviews, this is not a sprint, it's a marathon. And we need to have things in place that people can live with. And our government was very much in agreement with that. We need to find a way out of this that's not going to destroy more than it helps.
And what made you so confident, and I'll invite Sashi to comment as well, that it was going to last as long as it did?
I mean, historical evidence is very clear. Once you have the establishment of a disease on that kind of level, you can maybe stamp it out in isolated regions, but not on a global level. There is no way we can do that. So we had a new disease, and that disease is not going to go away by itself. It has happened in history. SARS disappeared, but that was the exception. The normal thing that we all know from history is that these diseases are going to stay. And our pandemic has normally been years. So why should this one be so much shorter?
And Suresh, was that what you were anticipating as well? You obviously took a different approach, but were you anticipating that without the approach you took, this was going to be long running?
Yes, indeed. We were expecting years, and we were discussing this just this morning, that actually if you had asked me in March 2020 to put money on there being safe and effective vaccines before the end of the year, I think myself and just about every other, and the experts, I won't put myself in that group, wouldn't have put any money on that at all. So in fact it was an amazing achievement, possibly one of the most extraordinary achievements of this century to date at least, to have developed not one but more than one highly effective vaccines within a much shorter period of time than we had anticipated. And as Dr. Tegnell had said, we had expected this would be several years. And in New Zealand, we knew that eventually we would end up with a community-wide outbreak, but we wanted to give ourselves as much time as possible to prepare for that, and certainly we were working on the hope that vaccines would come along, perhaps within a shorter period of time, and that's what transpired.
Thank you. And you offered a moment ago to explain the elimination approach. Could I ask you to do that now, and then I'll ask Dr. Tegnell to, just in a nutshell, describe the containment approach that initially Sweden was following.
Sure, and again, just to emphasise, when New Zealand went into its first lockdown towards the end of March 2020, it wasn't with the intention of achieving an elimination of the virus, but this was something that transpired. In fact, because the extent to which people responded to the call to isolate at home and to undertake a range of other measures. So that elimination approach, as it evolved, then during that period between March and perhaps June 2020, was characterised by very strict border controls, including a requirement that anyone coming into the country undertook 14 days of isolation in a managed facility. Full sort of population isolation, lockdowns if you like, requiring most people to stay at home in what we called a bubble, and we could, which was this idea was conceived actually by one of my a colleague of mine who's a medical researcher and a disability advocate, and he came up with this idea, and the idea which resonated enormously was that a bubble is something that's quite precious and you don't want to pop it, and so you keep your group within that bubble. Perhaps enough noise to burst the bubble just at the moment. This was a highly effective concept in terms of communicating to people that what was required of them during that first lockdown period. We had wide use of testing, and in New Zealand, because we were using an elimination approach, in fact, all testing was done laboratory testing. We actually banned the importation of rapid antigen and other testing. It had to be done in the laboratory because we needed the most sensitive and accurate form of testing to identify every single case. So widespread testing. Anybody who had any symptoms of a head cold or was encouraged to go and get a test, and it was all provided free and freely available. There was physical distancing of people when in public, so people were of course allowed to go out and go to the supermarket to buy food, but there were requirements for using a mask and physical distancing. All confirmed or suspected cases were isolated, and anyone who was a contact or identified as a close contact also was required to isolate. And also, subsequently, there was mandated use of masks and by both workers and members of the public in certain settings. So those would be the key features of the approach that was undertaken.
Thank you, and we'll come back to talk about some of those in more detail probably later today or tomorrow. Dr. Tegnell, if you could just explain briefly the containment approach and how it can be characterised in contrast with the elimination approach.
Or rather, the mitigation approach, which is basically the classical pandemic strategy of trying to flatten the curve. Because once you have sort of realized that you have an ongoing spread of the new disease in your country, and you have sort of decided we cannot stop it because it's just too big. Our main goal was really to try to get the curve as flat as possible, to not having a health services that was overwhelmed or too much spread to people who could not protect themselves and so on. And we worked with that in different ways. We did regulate many of the kind of restaurants, big events and stuff like that to diminish or close them down completely, but to diminish the meeting points, because what we are all then trying to do, and we discussed it also this morning, it's all about getting people to meet fewer people every day. And so in many ways we did similar things with New Zealand, but less drastic, if I may say so, because our goal was not really to stop it completely, but to get the famous R0 down as low as possible. And we did that very much by focusing on places where we could see that we had a lot of spread. We knew we had a lot of spread in the workplace. So we told people to work from home as much as possible, and we told employees make it possible to work from home. And that worked. 50% of the Swedish population work from home, which is, again, context. You can't do that in any country, but in Sweden we can do that. We also told people, if you have symptoms in the morning that could be COVID, any kind of symptom, stay home and wait and see what happens. And we changed the insurance way so that you got compensated from the first day, so people could actually stay home from the first day. And we also told people, please go out and meet people outside, but see to it that you're always keeping a distance. If you're going into a store, the store was told that according to how many square meters you have, you can only have so many people in the store at one time. So you need to have a system to sort of see to it that you don't have more. So all of these kind of things to try to find the places where there was a risk of spread and regulate them, but to let other things go on. We could, for example, find out by local studies that gyms was not a problem. We did some interesting, because we have so many registers, we could see that people actually going to gyms were not really at harm at all. So we said, please keep the gyms open. And we could see that different kind of training grounds for children and so on was not really a problem. So we said to the community, keep those open. The kids need to be able to be outside. So I think that's really what we try to work with. We try to work with the data we had so that we could find the places where there was a risk of spread and regulate those, but to leave as much of the rest. And by that, getting the R0 down, getting the curve flatter, making it possible for our health services to keep on running good services for everybody. We probably going to come back to, we had a problem with testing, because our testing capacity, especially in the beginning, was far from what we wanted it to be. And that's what part of the reason why we told people to, if you have symptoms, stay home. Mm-hmm. We don't have really capacity to test all of you, but so stay home instead, and after 24 hours it probably figures out if this is because of the beer you drank last night or if it's COVID.
Thank you, and we will come back to testing, definitely. My Lord, I understand that we were due to have a break a little while ago.
I understand as well. My mistake.
But we haven't quite finished, but we'll finish in a couple of minutes when we come back, so thank you very much.
Okay, we'll come back at 11:30. Thank you very much. Right, when you're ready, Ms van der Westhuizen.
Thank you, my Lord. Dr. Tegnell, I think I'm right in taking what you've already said, and right in understanding that Sweden made no changes to its administrative framework and that the principle of agency responsible in peacetime being responsible was maintained through the pandemic.
Yeah, I can just add there was a kind of coordination group within the government that is put in place during a crisis. That exists all the time, but had a special coordination role during a crisis, and my director reported to that group. So there did exist also a structure in there. But they were not really operational in that aspect. It was mainly a group to make it possible for the government to have joint, understand what was going on. And I mean, many different parts of many different ministries were, of course, heavily involved in this, so they needed that kind of coordination. But it's also good to know that the government in Sweden is one government. Each ministry is part of that government, and all decisions are taken jointly by the government. So we don't have independent ministries. We have one government with, of course, ministers all over the place. But when it comes to taking decisions, they're all taken together.
Thank you very much. Sir Ashley, you mentioned in your written response that the establishment of the Quinn, could you explain its membership and purpose and whether that was achieved?
Yes. The ODESC arrangement that I talked about earlier on is very much set up to respond to an immediate emergency or crisis. And as COVID evolved, it became clear that this was not going to be over quickly, and also that it was a very, very substantial crisis that would require an all-of-government response in the true sense of the word. And so the Chief Executive of the Department and Prime Minister and Cabinet established what was called the Quinn. That included an operational and policy leader out of the Department of Prime Minister and Cabinet, myself as Director General of Health, the Commissioner of Police, and also the Chief Executive of our National Emergency Management Agency. So this group was the key one that led the all-of-government response for a period through until the end of June or so. At that point in time, a COVID-19 group or directorate was established within the Department of Prime Minister and Cabinet, and this was a substantial grouping with a policy function, an operational function, a communications function, and so on. And that was responsible for supporting and leading the full all-of-government response. And then towards the end of 2020, there were two further things put in place. One was what was called our COVID Chief Executives Board, and that actually remained in place right through to the end of the pandemic. And this was the chief executives of around a dozen government agencies that were the key ones by that time, the main ones in the response. And also the Prime Minister appointed a minister, a dedicated minister for the COVID-19 response. And in New Zealand, a minister is the equivalent of a Secretary of State. So we don't have Secretary for States, but this was a minister who had other responsibilities, but primarily was a dedicated minister for the COVID-19 response.
Thank you. And we'll come on later to discuss decisions taken in relation to restrictions, but is there anything else either of you wishes to highlight before we move on to pandemic planning about the contextual in relation to contextual matters that are relevant to the pandemic responses? Please feel free either to raise them now or if anything occurs to you during the course of our further discussions.
No.
Okay. In that case, I'd like to move on to consider pre-pandemic planning and really sort of cover three topics under this: the nature and extent of pre-pandemic planning and resilience exercises. The usefulness of the plans, and then finally, I think you touched on it earlier, the personal protective equipment issues that you both experienced. So if we could start with the nature and extent of pandemic planning and resilience exercises, and perhaps start with Sir Ashley. And you say in your written response that New Zealand's pandemic plan was based on influenza, as I think many of them were, but it was intended to be adopted and applied to any pandemic event. Could you outline how that flexibility was built into the plan and whether it worked when faced with COVID-19 pandemic?
Well, I think I can be clear that the plan probably didn't have much flexibility, but it was New Zealand was not unique in that it was felt most likely, and is still the case now, I think that the most likely pandemic agent will be an influenza virus. Of course, that's not what transpired with COVID-19, but our prior pandemic, so-called swine flu pandemic in 2009-10, was an influenza virus. So I think there are two features of the plan that I can highlight. One is it was extremely detailed, and that it had been tested and exercised at both a national level and a local level. And the second point I would make is that it proved to be valuable for the first few weeks of response to the pandemic, but then after that we were learning it forward, would be a euphemistic way of saying it. And I think an important lesson here is that our responses, and this is where I think there's more in common between New Zealand and Sweden and perhaps other countries, the responses were very much predicated on basic public health principles. And if anything, we had done too much detailed planning around a specific potential virus, rather than thinking about what are the core public health responses that should be there, and then just test those against a number of different potential pathogens and scenarios. So yes, it was good that the structures were in place, and one of the structures that is in place is something that's called the National Health Coordination Centre that we established very early in January, which allowed us to start to coordinate the response nationally, and that was informed by the influenza pandemic plan we had. However, I think a key lesson for us has been that in our pillars of a response, what are the key public health interventions, and there are some that we had not even anticipated in our pandemic influenza plan, that we now have very, very good experience of both implementing and seeing what their effectiveness is.
And just in terms of what was foreseeable, to what extent did the plan envisage an all-of-government approach? You've obviously mentioned changes that had to be made in the face of the pandemic. To what extent was that recognised or anticipated in the plan?
So that's one of the features of the plan that was helpful. It envisaged an all-of-government response, and different parts of government had their own plans and operational testing of those plans. So that was something that I think was helpful. And of course what we found was that it required very much an all-of-government response. So I think having that structure, basic structure in place was helpful, at least for the first few months of the response.
Thank you. And we also understand from your written response that restrictions on movement within New Zealand were contemplated as an option to help protect isolated communities, who you've already referred to, the proviso that even in those communities, such measures would likely be considered only in exceptional circumstances. Why was this to be limited to exceptional circumstances, and what would have constituted exceptional?
Well, I think this goes to the point that we hadn't really anticipated, even because based on the swine flu pandemic in 2009, as it transpired, and there's some debate about whether or not it did constitute a pandemic at the time, its impact was relatively limited, certainly in New Zealand, and I just don't think we had anticipated something of the scale and impact of what happened with COVID-19. And so my sense is we reached the threshold for exceptional circumstances quite quickly, and that we hadn't imagined the deployment of, even deploying some restrictions on movement at a regional level was thought to be something that would be unlikely we would ever deploy. But we found within a couple of months, of course, we were not just restricting movements at a local or regional level, but nationally. Dr.
Tegnell, like New Zealand, Sweden's national plan was also influenza-based. Why was influenza the model used, and how much flexibility was built into that plan?
I think on a global level, almost all our plans were more or less openly based on flu, because that was what we knew. In a modern society, that's the kind of pandemic we've had during the last 100 years. Even if there have been blips with SARS and other things that could have constituted something. On the other hand, I must say that especially after both the H5N1 spread, I don't know how much that was, it was quite an issue in Europe and in Sweden. And after the swine flu pandemic, we had quite a lot of discussion on that it needs to be flexible. Because even a flu pandemic, if you look at the flu pandemics we've been living through, they have been very, very different. So there was definitely a need for flexibility. And on top of that, we also had the experience from the terror incidents with anthrax and so on. That was also a part of sort of what we had in the back of our head. So I think we had quite a lot of discussions on flexibility and try to build that into it. But, I mean, we did not cover. I don't think we really realized that it's going to be so different in many ways. Even if it in many ways, of course, it's also very similar. We're talking about a respiratory disease. It's spread in similar ways in similar places and so on. So there's a lot of similarities that we could use. So maybe at least to some extent, it was the restrictions we took and the decisions we took that were more different than from any previous pandemic than anything else. And that in itself constituted, of course, a problem how to handle that in a reasonable manner. So I would say that, yes, it was very good that these plans were in place. There were a whole of government approach built into them, even if that was not, I mean, it really developed much, much further during the pandemic. And I think that's definitely a lesson we take with us, that a whole of government approach might sound like one thing, but in practice, this was much, much bigger. And I usually say I have not talked to so many different parts of Swedish society ever before, like I did during this time, because everybody wanted to understand what does this mean for me. And I think it's really an eye-opener for many parts of the society, not least the non-governmental parts, which I think we really need to foster and keep on, because it's going to be very useful for public health in the future too. And we had a national pandemic committee in place, so we met with what we consider to be the essential services, and that was the veterinary side, it was the agricultural side, it was of course, our medical product agency, the contingency agency, and a few others that met once a year to discuss, okay, what is the threat right now, how are we developing our plans further, what kind of exercises and so on we're doing. So there was a lot of connections in place already.
And that was pre-pandemic, was it?
That was pre-pandemic. That started already, it started after the H5N1 that we had those meetings. And then, I mean, Sweden is part of EU. We are part of the Nordic region. Especially the EU had worked quite a lot on this. I had myself been working as a seconded expert in the Commission with developing these kind of contingency plans, and very much discussing also that we need to have a generic plan that can take care of many different things.
Thank you. Dr. Degel, at what measures did the national plan in Sweden contemplate, for example, border closures, quarantine or masks?
Nothing about masks, I would say. Quarantine does exist. That in our Communicable Disease Act there is regulations for how, by the decision of the director of the Public Health Agency, we can close off certain geographical areas in Sweden if there is a need to do that. So that was there. On borders, yes, according to IHR, there is even a special law in Sweden when it comes to international communicable disease control, which gives the provisions for what we need to have in place along borders to be able to handle importations and stuff like that. So that was in the plan, but not border closures to the extent that we talk about now, more about how can you regulate borders, how can you divert ships and airplanes to the right places so that you can take care of the people on board that might be sick and so on. So it's a different kind of border closures than the ones that were actually used in the end.
Thank you. And what was the extent of planning at the regional level, and did the template that's referred to for regional pre-pandemic plans that was supplied by the national level authority refer to social care, for example, including for care for the elderly?
Yeah, I mean, the operational responsibility was at the regional level to a very great extent. Almost everything we talk about was supposed to happen there. So the regions were also by law obliged to have a contingency plan. And for all of them, now when, not if you go like 10, 20 years back, there was more generic contingency plan, but after both the H5N1, SARS and the swine flu, all of them also had developed specific pandemic plans according to the template that we had provided to them. And we also had common exercises with them, both with them and also with other countries. And also collected those plans and did reviews of them. So there's quite a lot of communications around those plans.
And specifically, do you know whether they referred to care, social care, including care for the elderly specifically? Was that covered in those in the national plan template?
The relations between the regions and the communities when it comes to the elderly homes are very different in different parts and sometimes regulated and sometimes not regulated. They are basically focusing on providing good health protection in those places, what kind of protective equipment and so on you need to take care. I would not say that any of them really dealt very deeply with what to do during this kind of crisis. Of course, there were writings about how to establish cohorts in those places and those kind of things. But then you need to remember that the operational plans were then the responsibilities of the elderly homes. And that we knew because also that had been discussed and quite a lot of discussion with the communities about their need to also develop similar kind of plans, but they were far less developed than what had been done at the regional level. So that was really a weakness in the system, and that many of those did not really have any practical plans in place. What did exist in most places were some kind of connections when it comes to hospital hygiene procedures and so on, to help them to choose the right kind of face masks and other things like that.
Okay, yes, Ashley.
Could I just make a point here about this idea of whole of government approach?
Yep.
In a sense, it's constraining, and I think one of the lessons from COVID is that it's actually a whole of society approach. Because if you confine it to just being about government, it sounds like it's just the public sector that is responsible for all the action. Whereas, of course, we saw that the role of civil society organisations, communities, community leaders, for example, in New Zealand, Māori, disabled, immigrant, Pacific community leaders played a critical role. But in particular, the role of the private sector. And it was very important in New Zealand that just ahead of the first lockdown, there was a very strong consensus across all sectors of society, including from our private sector leaders, that this was the right thing to do. And of course, they had a very important role to play in terms of, everything from getting personal protective equipment, tests, vaccines, and so on. And so I think the notion of a whole of society approach should be one that we adopt and think about in our preparation and planning as well, rather than this somewhat constraining idea of whole of government.
Well, that's so good. Oh.
Just to echo that, because I completely agree, and that's definitely what we learned. And when I now meet with companies afterwards, it's interesting how innovative they became during this, how they managed to change the way they worked to get people to meet each other less, how they sort of changed the services they provided to protect people and so on. So many of the private companies did an enormous work in changing the way they did things. And we actually have statistics from one of the major companies in Sweden showing that actually people working there were much more protected than people who were sort of out in a more loose way, because they really could put a lot of things in place that protected their workers, and they had testing and so on in place. So I think we definitely need to understand this and support these companies in keeping that knowledge and understanding what they can do during a crisis so that they exist the next time.
Absolutely. Well, that segues nicely into the next question, and you've probably both partially answered it. It was really who was consulted in developing the plan in the case of New Zealand and the national and regional plans in the case of Sweden, and what considerations were factored in, and in particular I'm thinking of were they looked at primarily from a public health perspective with input limited to public health officials, or did they in fact include input from implementers, by which we mean organisations that would ultimately be required to implement the plan, such as, for example, police forces, local authorities, and did other stakeholders as well, you've mentioned some there, for example, health and social care providers, business representative organisations and trade unions, for example, have any input at the pre-pandemic planning stage prior to the pandemic, or obviously. Yes, please.
So I can certainly speak for the health system in that there was very strong engagement with and input into both the preparation of the plans and the rehearsing of the plans from our wider health system, and that would include both those working in hospitals and those working in the communities in primary care, aged residential care and other community-based services. What I can't comment on quite so much is the extent to which perhaps before I say that, and there was also involvement of a number of key community groups and leaders, and our Māori are divided into, the English word for it is tribes, but the Māori word is iwi, which are regionally based, and they have leaders forums that were engaged, and so there were connections there. What I can't comment on quite so much is the extent to which government agencies that might have more interaction directly with the private sector beyond the health system had mechanisms in place for both canvassing their input into the development of plans and also establishing communications and operational responses. However, judging by the response of those who worked in the private sector, I think they felt they could have been more involved, certainly in the response, and I imagine that would carry over to the preparation and planning as well.
Okay, thank you. And Dr. Tegnell, what about in Sweden?
No, I think the situation is quite similar. I mean, the plans were sent for review to what we, before the pandemic, considered to be the important actors, but I'm sure today we would have shared them with and made it possible to have input from many more than we had in those days. So definitely it's something we learned, that it's a much wider spectrum of actors that we need to involve in those kind of things. And the plans were very much, I have to agree on that, focused on health, public health and the public health services and so on. And they were supposed to be complemented by the civil contingency plans that MS will continue working with. And those plans, because we had a lot of collaboration with them, and those plans, I think, to a certain extent, took this kind of crisis also into account, but maybe not reaching out as much as they would today if we did it again.
Thank you. And just briefly, to what extent did the plans in both New Zealand and in Sweden take into account the needs of vulnerable groups in particular, for example, including the elderly, which already touched on, care homes, disabled children, those at risk, for example, from abuse, those in care homes, including the elderly and those with profound intellectual and multiple disabilities? To what extent were those vulnerabilities and needs of those vulnerable groups factored into planning?
Yes, so that was certainly a key consideration in the planning, and as I've said earlier on, a very important consideration in guiding and determining New Zealand's response to in both the early days and the subsequent response to the pandemic, and also in the rollout of the vaccination program as well. So yes, that need to, because this is the thing with pandemics, is you know which groups are going to get hit hardest. You can identify them up front, and I dare say, one of the things I find now is when people approach me in the street, that it's very often to their gratitude for the fact that the response protected vulnerable members of their family or their community, either people with existing medical conditions, children with disabilities, people with mental health conditions, older people in particular. So we knew who those vulnerable populations were likely to be, and they were very much a factor in the pre-planning.
Thank you. And Dr. Tegnell?
Yes, I mean, the plans did not really specify them very much, but it specified very clearly that the importance of finding the vulnerable groups and act to protect them. I mean, that was a very, very important part of it. And also, during the pandemic, it was something that was very, very much in our minds. And we did a lot of analytics using the registries we have in Sweden to try to find those groups in different ways. And many of them, so we really learned a lot of that. And both that some groups were very much at risk, but also to some groups that felt themselves being at risk were not at risk. Teachers, for example, because the teachers were quite worried about having to go to school and meet all these kids. But since we had these registers, we could run and see that teachers were not at risk. And if they were at risk, it was because they met each other, not because they met the kids. So it was very useful in both identifying who we did protect, but also trying to alleviate the fear in certain groups that they were not really at risk. So this is, as my colleague said, very important of the pandemic plan is to try to find those groups as early on and protect them very clearly. And the Swedish analytics showed really very, very clearly that at risk was the elderly. Everything else was completely secondary. Chronic diseases, not very much. And also homeless, for some reason, were more or less protected. So there were some interesting aspects to it that we did not really suspect. But the elderly came through. It's very, very clear, a risk group.
Well, we're interested in exploring with you after lunch the data and that both your countries used, so we'll no doubt talk more about that. In relation to services, we've touched on them, and I suspect, Dr. Tegnell, from the answer you gave earlier, that your answer is that they continued. But what services were considered in pre-pandemic planning to be essential to maintain in the event of a pandemic? For example, those needed by people with PIMD, acute healthcare, speech and language therapy, physiotherapy, specialist education and services needed for women and children and other vulnerable groups, to name but a few. To what extent were the services for those groups considered in the pre-pandemic planning, or the need to continue those services in the event of a pandemic?
So my view on this would be that we hadn't considered that very much because we hadn't actually anticipated the level of disruption that the pandemic caused, not just to health services, but just right across society. And of course, within the health system, there were two aspects to this. One was under the elimination approach, where many non-urgent medical or healthcare services were paused during the equivalent of lockdowns. And the second was the redeployment of staff to do other things, whether that was helping to care for people or in particular to help vaccinate people when the vaccination program got underway. So again, I don't think these were things that we had necessarily anticipated. And there was a lot that we learnt about what would be required. And so some of the non-urgent services, and not just elective surgery, but as you've alluded to, services that are essential for people's well-being and recovery, like speech-language therapy, other allied health services, were paused for periods of time. One of the areas that we were able to maintain, even in very strict lockdowns, access to was cancer care, and we didn't see our Cancer Control Agency took a careful look at cancer outcomes during our response and during the pandemic, and found that there was no no real drop in outcomes from cancer care.
Thank you. And Dr. Tegnell in Sweden.
Because we are coming back to the civil contingency laws and regulations around that, and those laws and regulations are very clear about that you need to keep on providing the services also in a crisis. The big discussion we had is what are essential services, because that's a very, very difficult subject to approach and how to deal with it. And I would say that what we focused on was a big loss of people, so that the services could not be supplied because people were not available because they were sick or something else. So this was sort of the kind of scenario we gave to them, and mainly to our contingency agency to work with. But there was a big problem in trying to sort of say who are essential services. And mainly we're coming back to you need to work with business continuity, keep the thing. So it came down to the individual services. You need to understand how many people you need to have in place to be able to run your services, and how can you redeploy the people to actually manage that. And I think that in most instances that worked reasonably well, probably because we didn't close down completely, so there was no loss of people because of that, and that people in working age groups were not sick all that much, that we had sort of anticipated to a certain extent, so that people were available and could be redeployed in a way that I think we're also trying to measure the impact on chronic care and so on. We cannot really see that we lost very much. Our average age went down for a few months during the first year, but then very quickly came up again. And our the extra deaths during this 3-year period in Sweden was minimal. So our health services, I think, even if we haven't looked at the specifics very much, seems to have been able to deliver. And also the services to disabled and so on were very much kept in place. So it, even if, somehow, sometimes probably diminished to a certain extent, but it's since the responsibility is so divided, so it's very difficult to make any kind of analytics of it. But if you look at the outcome, it looks reasonably well.
Thank you. Just touching finally on this topic, resilience exercises, I think, so Ashley, could you please first explain the nature and extent, you mentioned them earlier, of the resilience exercises undertaken in New Zealand before the pandemic, and how regular they were and what agencies were involved?
So there were two types of exercises undertaken. There were sort of health system focused ones that would involve the Ministry of Health and the district health boards and the other organisations that they would have links to, local general practices and so on. And then the other were that sort of all-of-government type exercise. I would say they were infrequent and arguably inadequate. So saying, to go back to my earlier point, often the focus was on quite detailed responses by each agency, and I think the key lesson is a key lesson is having a broader, more agile framework, testing it more frequently with just a range of different scenarios. So that was a key lesson for us.
Thank you. And Dr. Tegnell, I think the current Commission's report noted that the pandemic plans at regional and municipal level were outdated or lacking, and I think you mentioned in your response that the principal preparedness exercise had been conducted, I think, 10 years before the pandemic. Are you able to say more about that gap and any implications for responding to the pandemic?
I must say I don't completely agree with the statement, and I don't know what to base it on, because we did make collection of plans, and we found plans everywhere and reasonably often updated. When it comes to exercises, not as much. I think the health services do a fair amount of exercises, but they are mainly focused on catastrophic events. like a big train crash or something like that. And they do that reasonably often, and they do it very well, and they handle those kind of crises also very well, because it's very much these kind of long-term crisis that we had this time is very different and also very difficult to exercise in a meaningful manner. So that had not happened very much. We do a number of exercises, both because we do them nationally, very infrequent, I must say, but there's also initiative from the EU level, so we're also involved in those kind of exercises. But mostly in a fairly small group of agencies and so on. So this kind of whole of government testing and so on is done very infrequent. I agree with that. But they are not completely easy to do. We often tend to try to exercise a certain part of it, like the startup of things. So, yeah, things like that, to make it manageable.
Thank you. The next topic, I think you've probably covered some of this ground already, is the usefulness of plans. And so actually in practice, and how useful was New Zealand's influenza plan with its built-in flexibility once COVID arrived? And I think you have answered this partially in the sense that it provided sort of a starting point. But was there anything you wanted to add in relation to that? I think you said it provided a framework, but that unforeseen measures were needed. Anything more to add in relation to the gaps, where those gaps emerged, for example, around border closures?
Well, just to reiterate the point that I don't think we had anticipated anything of the scale and the speed with which the COVID-19 pandemic evolved and the impact it had, and so we found ourselves having to be extremely agile, and the plan, the influenza pandemic plan, within the first probably 6 to 8 weeks of the pandemic, had done all that it could do. One of the most important features of it was, though, that there was this framework for organising ourselves and for decision making that at least saw us through those first 6 to 8 weeks.
Great, thank you. And Dr. Tegnell, you've described Sweden's plans as a good start, although I think others have been more critical. What aspects did you find the most useful?
Probably the most useful part was that the development of them meant that we had a kind of network in place, that we had talked about this, and we had met with other agencies also involved. We had quite a lot of meetings together with the medical officers out in the regions around it. So we knew who we should talk to. And I think that was the most important part. And some initial things like the testing and tracing in the very early pandemic, those kind of systems were very much in place. But after a while, we tended to go much more into sort of trying to use our data to see how do we deal with this in the best possible manner, where are we going, and what can we possibly do to make it as reasonable as we can.
Thank you. Finally, just under this theme, personal protective equipment for both countries, we're interested in hearing about things such as the apparent failure to audit and maintain stockpiles, which I think you've touched on, including who was responsible and the cause, and as well as the adequacy of planning for the potential need for PPE by those working in areas such as, for example, healthcare, education and policing. If we could perhaps start this one with Dr. Tegnell. I think the Corona Commission again found that Sweden's emergency stockpiles of PPE and medicines had been dismantled over a period of several years, leaving almost nothing at the start of 2020. And I think you described that situation earlier. Could you please explain who was responsible in Sweden for maintaining the stockpiles and whether audits were conducted on the levels and types of PPE and the reason for that failure to maintain them? Is that known?
I'm not completely sure what the Commission means about dismantling earlier stockpiles, because the earlier stockpiles were really stockpiles for war. Okay. They were dismantled because they were not really useful anymore. We had, for example, drums of chloramphenicol. Chloramphenicol is an antibiotic that's not used anymore because it has side effects, and they were in drums. So these kind of things exist, and they also were respirators from the 50s and stuff like that. So most of these things were not very useful and meant for a completely different kind of situation. So the dismantling of those, I think, really didn't have anything to do with the main problem, which I was alluded to earlier on, that nobody kept stockpiles. And we had, I think, at least 3 different government reviews over the years looking into this and saying that we really need to do something about this, but nothing really happened. Partly because of the reason that, from a legal perspective, the responsibility lies with the regions. But the regions did not really agree with that. They thought that, okay, in this kind of crisis we're talking about, we need the government, the national government, to be more of a, at least financer of those kind of things. And they were never even, unfortunately, never really able to reach a consensus on how to handle this until now. So there were no stockpiles anywhere, and even the agreements with suppliers did not really provide for any stockpiles at their level, which sometimes I think is maybe even better than running your own stockpiles to get your providers to keep stockpiles, because you don't want things to get old. So you need to really have a revolving stockpiles, and so not that easy always. I mean, you don't buy 1 million mouth coverings and say that now we have fixed this. This is much more of an operational thing that you need to keep on running. I think we learned a lesson, at least to a certain extent. The regions have taken a completely different kind of responsibility in this and started building up, both having agreements and actual stockpiles in place. So the situation is much better. And I know that we have current reviews ongoing if we should do something like what they do in Finland, where they have a law in place saying that you need to keep, I think it's 3 to 6 months stockpile of any things like this, if you run a if you run a hospital.
And Surashi, New Zealand also found that stockpiles of PPE had not been regularly monitored or updated. Who was responsible in New Zealand for maintaining those stockpiles, and were audits done on the levels and types of PPE available?
Yes, so probably a similar experience in New Zealand. And there were 2 things here. One, as you've alluded to, there was an expectation that each district health board, as part of the national stockpiles, would have their own stockpiles of PPE, particularly masks and gloves. And it became apparent very quickly that there was highly variable, highly variable around the country, both in terms of the numbers and the whether they were up to date between district health boards. And certainly this issue of actually revolving the emergency stockpiles with everyday use. So there was that issue, and it became apparent that not only had the stockpiles in most regions not been kept up to date, but they had also been, and the volumes were anticipated for the hospital system, but of course they were also needed for our providers out in the sector, in particular in aged residential care facilities, and also some vulnerable people who were living in the communities in vulnerable groups. And whilst those, most if not all of those health service providers in the community were private providers, as soon as an emergency happened, they had an expectation that they would be able to access the stockpile. And so that brings me to the next point, which is actually the size of the stockpiles were much more suited for, it's one thing to have 3 to 6 months worth of supply for everyday use, but the requirement for changing face masks regularly and just, you needed a much greater stockpile than perhaps had been envisaged. And of course, then we all found ourselves around the world wanting the same PPE at the same time, and the prices went to astronomical levels. And even then, even if you could get it, it was often a waiting list. So I think this was something that was a lesson for most countries.
Thank you. And then a question for both of you. Was it recognised in pandemic planning in New Zealand and Sweden that PPE would be required not only in hospitals, but as it transpired, for social care, education and frontline services, such as, for example, the police?
Well, I can continue. I sort of made this point that actually I don't think we had anticipated that requirement, and given it was only the health sector that had the stockpiles and was responsible for the stockpiles and was only really envisaging the use of those stockpiles in hospital settings, perhaps also in community-based health providers, but there were all those other situations or settings where masks in particular, it transpired, were going to be very helpful. I mean, the other thing is early on in the pandemic, certainly in New Zealand, and I don't think we were alone, there was a great deal of emphasis on transmission of the virus by touch and cleaning surfaces, and one of the reasons that our infection prevention and control experts gave for not necessarily promoting widespread use of masks, even if they had been available, was that there's a certain technique required to put on a mask, and that could then, people could end up with virus on their hands, and that would transmit. As it transpires, it was probably a red herring, because it doesn't matter if you're an expert or not, and using a mask, just putting one on is actually, it transpired was one of the most useful things that could be done. So we learnt a lot about the value of masks for any respiratory pathogen, pandemic and future. And I think this is one area where I think many countries are considering ensuring they have the capacity to manufacture onshore should the need arise.
Thank you. And Dr. Tegel,
No, I think the situation in Sweden was very similar to when it was mainly a health service kind of thing, and it was mainly the hospitals who used them and had them to a certain extent, sometimes in the elder care, but they neither had the structures in place, nor the training in place, nor the stocks in place to use them to an extent they should. So this was really a big problem. We never really saw the use of face masks out in public in general, even if we could sort of see that there might be certain places at certain times they can be useful. But I mean, it's a complicated matter, and not least the volumes you end up needing is going to be astronomical if you're going to use them in the right way. I did a quick calculation. We talk about 1 billion masks a month in Sweden if you use them as you should. And I think our experience in Europe is that, yes, masks were all over the place, but very seldom here. So I think if we want to have the good use of them, we need also to rethink our strategies and how to use them, and also, once again, try to find out where do they actually make the most use, so we don't end up telling people that you go out for your morning run, you need to have a mask on. So it also needs to make sense to people that, okay, if you need to take a bus that's already full, yeah, sure, then it might make a difference. But if you take your bicycle to work, you don't need it. So I think once again we need to work more on that.
Thank you very much. We are about to move on to our next. We have about 10 minutes before the lunch break, so I'll perhaps start the next theme, which is the timing and extent of lockdown. And the first topic under this is the timing, nature, and extent of lockdown restrictions. And we've touched on this already in part in relation to the overview. But if I could start with Sir Ashley already, you've already given an overview of how New Zealand's strategic approach evolved from the early cabinet led to the adoption of elimination and the reasons for that approach. But if I could ask you, I understand New Zealand adopted a 4-level alert system on the 21st of March 2020. Could you please explain what the 4 levels looked like and how they operated in practice, please?
Sure. So the 4-level alert system was finalised in the Prime Minister's office on Friday the 19th of March 2020. As you can tell, it's something that sticks in my mind because I was there. And the next day she presented it to the country, and this was a point in time where we had an increasing number of cases in New Zealand, and this alert level system, I think, was an outstanding tool for communicating to the public about what to expect in the days, weeks, and actually we anticipated weeks and months ahead. As it transpired, it was the days ahead. And the 4 alert levels, and these are available, and I refer to them but in my submission, but effectively alert level 1 for New Zealand anyway was life as normal, except the borders were shut. And this was called prepare, so it wasn't the do nothing level. But effectively it relied on very strong border measures to maintain our elimination status. Alert level 2 was reduce, and that was when we felt there were some cases in the community and certain measures were required to just help, as Dr. Tignall has described, sort of reduce the likelihood people would have contact with other people. But effectively businesses were able to open, schools were open, health services were running as normal. Hospitality businesses might have to might be required to have distancing between people, so a maximum of 100 people could be present in a venue at any one time, and so on. Alert level 3 was called restrict, and this was the point when people were required to stay home in their bubbles unless they had to go out to work or school, or they could go out for local recreation. In fact, under that level, schools were still open, but there was just trying to reduce non-work and non-school related interaction, physical distancing outside of the house, and so on. Now, alert level 4, which was actually called lockdown, was the one we moved to very quickly after that initial presentation of the alert level system, and within 5 days we were in an alert level 4. So this is the stay-at-home order, really. People were still allowed to go outside for safe local recreation. There were some very interesting restrictions around that. For example, people weren't allowed to go into the sea to go surfing or swimming, or to do activities that might require the emergency services if they got to deploy if they got into trouble. But one of the things that characterised that point in time was there was no traffic on the road, so you would see families walking around the neighbourhood down the middle of the road, keeping safe distance from other families and actually spending more time interacting with their neighbours than at usual times, but from a safe distance. All gatherings cancelled, all public venues closed, educational facilities from early childhood education through to tertiary education all closed, and healthcare services very much all being delivered to the extent possible online, with face-to-face contact restricted to emergencies and acute care only. So this alert level framework was explained by the Prime Minister to the country. The country went into alert level 2 just to gear up, really, on it must have been the 21st, Saturday the 21st. By the 23rd we were in alert level 3, and by the 25th we were in a full lockdown. So that then provided a way to really communicate to people what they could expect during what was a really extraordinary, unprecedented and quite frightening time for everybody.
Thank you. And could you just explain briefly how the level system continued to be used until the arrival of the vaccine? You obviously had other interventions or measures in place around that time, but just specifically the light system, and broadly what the drivers were. We'll come on to discuss in more detail, but broadly what the drivers were for easing the restrictions and the imposition subsequently of 2 further national, we'll call them lockdowns, for and when they were and what those looked like.
Sure. So the alert level system, in fact, was also helpful as in the first lockdown, as it became apparent we had really broken the chains of transmission and the number of cases was dropping, until we reached a point in time when actually we had no cases detected for several days in a row, and then we started to move down through the levels. So it was helpful, and in fact it became mostly useful for coming out of the full lockdowns, because what transpired when we had a community outbreak in August 2020 and then in February 2021 and then again in August 2021 was the response was really, as soon as we found that first case, to go immediately to either an alert level 3 or 4, so very tight restrictions until we found out what was happening, and then we could ease them quite quickly. after that, and people had become used to them and knew what to do and what to expect after that. So, yes, that framework was used right through till the end of 2021, when we had vaccinated a very high proportion of the population, and we moved to a subsequent traffic light system, which wasn't as well received or as well perhaps or as useful, because it was much more challenging coming out of an elimination approach than it was going into it.
Interesting. And at the outset of the pandemic, was it foreseen that different levels might be used in different parts of the country? I know you've spoken about vulnerable groups in particular parts, but was that something that was foreseen?
It was anticipated that you might just put restrictions in place on different regions, and that did happen when we had our subsequent community outbreaks that all started in Auckland. As in Sweden, that it's the cities really where these outbreaks would start. Auckland was our main or only point of entry from outside, certainly in terms of air travel, and all three community outbreaks started in Auckland. And in fact, the longest one that went from August until November 2021 was the Auckland and north of Auckland and south of Auckland region. And so that did require the implementation of essentially land-based borders to restrict movement between different regions, which was a very big challenge. But it did also show that you could, certainly in New Zealand, you could restrict or control movement between regions where you had where there was contiguous geography. New Zealand's strategic advantages. It's also a strategic disadvantage at times, but a strategic advantage is we're small islands really at the bottom of the world and surrounded by a lot of sea. So that gave us the opportunity to implement an elimination approach. But later on, when we were still using the alert system, we did get experience in how you managed a land border. It was extremely resource intensive, especially for the police.
Okay. Thank you. We've got 2 minutes. You mentioned bubbles already, and it sounds like they were invented there potentially by your colleague. But what levels were permitted and under what circumstances were bubbles permitted? Was it, for example, lone households, sole carer, elderly? In what circumstances were they permitted?
So the bubbles came into play during the severe restrictions or lockdowns, and the idea was that inside your bubble were the people who you normally resided or worked with, and it allowed people to put in place arrangements. For example, if they had an elderly relative who usually lived alone, that person could come and live with them and be part of their bubble. So we deployed this idea both within the household setting and also within the workplace. We would often have different teams working at different times, and or if they were in the same workplace, they would only associate with the people in their work bubble. So we found it a really useful way of again, to the key point here, slightly different approaches, but what we were trying to do was just minimise the interactions people had with others for a period of time to break chains of transmission.
Thank you. I think we have a minute left. I don't want to waste time and lose it, but I think we'll probably go over if we start now, my lord. So.
Very good. Very good. We'll come back after lunch at 1:30. Yes, 1:30. Thank you.
Thank you.